I have had a huge number of patients who've benefited from this group from just being able to connect with somebody their own age. I've had patients who needed help with insurance coverage or co-pays on medicines. I've had patients who wanted to talk to folks who've been through a stem cell transplant. And in all of these cases, I've been able to talk to Anne or Michelle or somebody and get you linked up. So when they say they have your back, that's not just lip service, that's true. All right, so I find it helpful. Allison and Brady are going to talk a lot about the vascular complications, including cardiovascular complications of these. And I felt that maybe it would be good for me to start with talking a little bit about what myeloproliferative neoplasms are. Why are they called cancers? What are some of the risks that patients face? What you go through when you're diagnosed, and whether or not you've been through all that you need to go through to know that you have the disease that you have. A little bit of a stepwise thoughts about treatment. Now, Gabby's going to go into more detail about the pluses and minuses of each treatment. Oh, sorry. Gabby's, I'm a walker, and they don't want me to walk, so I'll be standing here. So we'll talk a little bit about what are the background ways that you should avoid affection, that you can optimize your cardiovascular and vascular health, and you can limit your risk for other cancers. And then we'll just end with discussing strategies for provider-to-provider communication. And then either, Anne, I didn't tell you this, but it's possible that then Allison will get up and give her talk, and then we'll do my clinical trials talk, okay, just to give them a break from my voice, okay? We are here all day. I know I sound like a comedian, I'm here all day. Tip your waiters. But if you guys have individual questions you want to talk about, come up, get advice. That's what we're here for, okay? Now, we don't know your case. We haven't looked at your record. We can't give very specific advice, but we can definitely speak in general about the types of things that you and your physician should be talking about. So use us as resources during the course of the day for questions or whatever. All right, so what is a myeloproliferative neoplasm? It is, we talk about it as a blood cancer. It's really a cancer of the bone marrow because it's a cancer that develops in the stem cell. Now, I have a couple of patients here. They will know that I'm always talking about this garden analogy. So the inside of the bone marrow, I want you guys to think about as a garden. And that garden should be producing plants. Those plants are your blood cells. And every plant starts with a seed, and that seed is a stem cell. Now, these are not the stem cells you hear about on the news. These are not going to grow into an eyelash or a skin or a tooth or a heart cell. These stem cells only grow into blood cells, and so they are known by the term hematopoietic stem cells. And when this cancer starts, it starts in a stem cell. So a breast cancer cell starts in a duct cell of the breast. A pancreatic cancer cell starts in a pancreas cell. But a blood cancer cell, in particular the myeloproliferative neoplasms, start in a stem cell. You're born with these stem cells, and your entire life, these stem cells make more stem cells and produce blood. And if you can imagine a garden that you could plant with a single seed and expect it to grow rutabaga and tulips and basil and tomatoes, that seed would have a lot of very complex DNA inside of it. And the more complex, the more likelihood that there might be some vulnerabilities. So here's our stem cells inside our bone marrow. And here's what normal hematopoiesis, which is the fancy schmancy word we use for creating blood. Normal hematopoiesis is this stem cell taking a number of steps to become your white blood cells, which are your immune system. And these include lymphocytes, like B cells and T cells. These include neutrophils, and these include the red blood cells, and these include, you also take multiple steps to become a red blood cell and multiple steps to become a platelet. Your red blood cells, as I don't need to tell this audience, carry oxygen throughout the body in the form of something called hemoglobin and platelets. And I always think about platelets as the bricks of the blood system that basically wall up areas that are bleeding. So the normal bone marrow starts with a stem cell, and this is the kind of graph that every medical student needs to learn. It starts here with the stem cell, and then signals come in from outside and say, hey, we're bleeding. So maybe you could make some platelets, which come from these things called megakaryocytes. Or I'm infected with mono. Maybe you could make some lymphocytes for me to fight off mono. Or, you know, I'm pregnant, I'm really anemic. Maybe you could make some red cells. And so these signals, the bone marrow doesn't know if you're pregnant, the bone marrow doesn't know if you're bleeding, the bone marrow doesn't know if you have mono, right? It follows signals that come into the bone marrow that tells this choreography to happen. And correct function of this bone marrow requires that that stem cell is able to make its progeny, that it's able to make more stem cells, and that it's able to kill off its progeny when they're not doing their job or when there's an error inside of them. So these hormone signals, you'll recognize some of the names. They include hormones like erythropoietin, or granulocyte stimulating factor, or thrombopoietin. These hormone signals tell the bone marrow, hey, it's time to make red cells, it's time to make platelets, and it's time to make white cells. And they do that, the stem cells know that because they have these little receptors on the outside. And those receptors, if this is the hormone, those receptors sense that the hormone is there, and therefore they go on to make blood cell production. So here's your erythropoietin, here's your receptor, your stem cell says, hey, there's a lot of erythropoietin here, I'm being told to make red cells, I should do that. These receptors include something called the JAK2. And so when you have a mistake that occurs in this, what ends up happening is these normal stem cells make new stem cells, or make new red cells or platelets, even when the hormone's not there, because there's a mistake in that receptor. Now, oncogenesis, again, a fancy Greek word for the creation of something oncologic or cancerous. And this is what, when an error happens in a stem cell, we call it oncogenesis. And what could cause this? Well, it could be from radiation exposure, for example. We talk about that in some kinds of leukemias, people that we know from Hiroshima or other exposures to radiation that can cause problems in the stem cell. We know that certain chemicals, high levels of benzenes, perhaps Agent Orange, can cause problems in the stem cell. Smoking can cause problems in the stem cell and is the reason why mutations happen inside, and people who smoke are more likely to have myelodysplastic syndromes and certain leukemias. But the most important thing that happens is time. Over time, these mutations can happen, and so every decade of life, there's more likely to be some mutations in the stem cell. And those mutations get passed along to progeny. One of those mutations, if it happens inside that JAK2 receptor, means that this particular stem cell thinks that it's always hearing the signals of the hormone, so it's going to make increased blood cell production. The cells that are going to make aren't going to be quite the same as the normal cells, and they're not going to interact with your blood vessels the same way. So people have an abnormal population of red cells or platelets or sometimes white cells, and that can increase the problems between the blood cells and the vessels. So now you have a garden that's got a lot of good cells, but it's got a bunch of cells that have this mistake, and their daughters and granddaughter cells have that mistake also. I think of those as weeds. Sometimes more mistakes happen, because once you've got one mistake, then the garden is vulnerable to more. The mistakes tend to multiply. And when I think about ET or PV, I think more about a garden with really just a few mistakes, one or two mistakes. So one kind of weed, more or less. But when I think about myelofibrosis, I think about a stem cell that's had multiple mutations over time. And that's one of the reasons myelofibrosis tends to happen in older people. And in those cases, you've got some cells that look like that first mutation, and then some that have additional ones, and then some that were really weird, and now you've got some fibrosis forming, and over time what you've developed is a chaotic, weed-filled garden. And that fibrosis and the chemicals that are sent off by these abnormal stem cells are why people feel symptoms. Symptoms like fatigue, symptoms like night sweats, simple symptoms like weight loss. In addition, when you get all this fibrosis in the marrow, then it's hard for those good stem cells to even make the plants they're supposed to make. And so the body starts looking for auxiliary places to make blood. When you're a fetus, before you have bones, your blood is made in the spleen. And when you run out of space inside the bones, the body starts looking for other places to make blood, and it goes back to this primitive place that used to make blood, and that's the spleen. So the spleen and a little bit of the liver have blood-making capacity, and the more fibrosis that you see in the marrow, the more likely that the spleen or the liver or other places in the body will start producing blood, including places that ought not to. So this is really the garden of myelofibrosis. It's chaotic. It has this scar tissue in there. And there's not just one error, but often multiple errors that have occurred. That's why if you do genetic testing, next generation testing on people with myelofibrosis, they often have multiple mutations that we can see inside those stem cells. And this leads to the clinical picture that many of you face. So in folks with, for example, folks with essential thrombocythemia or Polycythemia Vera, you see high levels of blood count. You can see sometimes bleeding or bruising. But the biggest problem is problems with clots, and that's because of the abnormal interactions between the blood vessels and the cells that are being made, so arterial clots and venous clots. In people with myelofibrosis, so the increase in this scar tissue inside the marrow, you can get an increase in spleen size, which can lead to really people feeling quite unwell and decreases in their appetite, fatigue in particular, night sweats, etc. So once these diseases are diagnosed, patients face risks. The biggest risks are the risks of a heart attack or a blood clot in the veins, which we call a pulmonary embolism or a deep venous thrombosis. But people also face some risks in terms of infections, risks of bleeding, because again, those blood vessels don't interact the normal ways with their blood cells, and then arterial clots in the brain that can cause strokes, or even blocks of the veins of the brain that can cause something called cerebral venous thrombosis. So when we meet a patient with essential thrombocythemia or PV or myelofibrosis, our job is to say, what are the main risks that you particularly face, and how can we best intervene on those? I think one thing that we've really learned about myeloproliferative neoplasms in the last several years, probably in the last decade since the work of Dr. Mesa in this, is that many people who may not have these kind of traditional objective risks that we talk about, many people still have a lot of symptoms. And those symptoms are not, they're not nothing. And they actually impact the quality of life of people who previously a doctor would say, oh, your blood counts are fine, they're under control, go home. Now we know we really need to pay a lot more attention to people's symptoms, and these include symptoms of fatigue, which is pretty universally prevalent in all three bone marrow conditions, pain or itching. So I put this picture up here because of itching, and itching is a classical symptom of Polycythemia Vera, a little bit of ET, but also myelofibrosis, but also pain. I think bony pain is something we see with myelofibrosis, but just kind of aches and pains that sometimes seem a little bit higher than normal. And then one of the things that's also come out is problems with libido and sexual dysfunction are also very common, perhaps related to vascular, perhaps related to fatigue, but also something where the medical community has yet to catch up on ways to address any of these. So I want to step back a second and just make sure that everybody understands what we think about when we diagnose people and what the steps are for diagnosis. So everybody, before they have a label placed on them, needs to go through some basics. And these basics include, of course, a medical history. We try and do this thing called the MPN Symptom Assessment Form Survey. And so typically this symptom assessment form is a question of about 11 to 12 questions. I think it's like 10, and then there's an adjunct of 5. But these allow you to rate your symptoms. And then periodically, once a year or more frequently or less frequently, you should take this survey again, and your doctor can print it out off the internet. And this just allows you to rank, this is what I'm feeling. Now, the MPN Research Foundation is doing something sort of much more exhaustive than this that allows you to keep track of symptoms. But this is something that I kind of collect every once in a while on my patients, and it gives me an idea, is this treatment working? How are you doing with this? Of course, you need a physical exam and then blood counts. It's essential that somebody check your erythropoietin level. For patients that are diagnosed with polycythemia vera, meaning they have too many red blood cells, if their erythropoietin level is high, that means that this isn't polycythemia vera. That means that their problem lies in the fact that their body's overproducing this hormone for some reason. Twice in my career, I've had people sent to me because they have polycythemia vera, and then we check an EPO level, and it turns out one of them had a tumor of the lung, and one of them had a tumor of the kidney, and those were producing EPO, showing somebody to have polycythemia vera, but they didn't. They had something else. So this is a key hormone level that needs to be checked in all patients who have suspected PV. In my clinic, every patient gets a bone marrow biopsy for diagnosis. Now, this has been reinforced by the World Health Organization 2016 criteria, but I also think it's a good idea because if somebody you can't tell from the outside if somebody has myelofibrosis versus essential thrombocythemia, for example, and making sure you clarify that, also getting a before picture. I know people don't like a bone marrow biopsy. We'll talk about that in a second, but we don't have any better way to look at that garden. And so it's really important, I feel, that most patients start with this. We need to make sure that people have ruled out a common condition called chronic myelogenous leukemia, called CML. And that's because there's very specific tests for very specific treatments for CML that are not present in myeloproliferative neoplasm, so you need to make sure that's ruled out. And then patients need to have molecular testing for both kinds, for the JAK2 mutation. If that's positive, you don't have to move on, but if it's negative, you get the JAK2, the exon 12, and maybe these MPL and CALR mutations. And there are certain circumstances where I also do more extensive next-generation sequencing on patients. And that's where I send their blood to a place that actually looks at a number of mutations. Now, I tend to do that only in myelofibrosis because that's helpful for me when I'm thinking about something called transplantation. But it is something to ask your doctor, do you think I need NGS sequencing or more molecular testing? This is a bone marrow biopsy for those of you who've been through them. It's where we take a small sample of the inside of the hip and you numb up the skin. If this is the bone marrow sitting underneath the skin here, you numb up this area and you stick a needle through the skin to basically take a sample of the soil of the garden and pick up as many stem seeds in there as you can to take a look at them. There's plenty of patients here who've had bone marrow biopsies, so you can talk to them if you haven't had one. I haven't had one, although my mother says I should go through one just so I know what it's like. She has a point, but I still haven't done it. I will tell you that the more that you do, the better that you get. Most people should not be, in my opinion, shouldn't be put to sleep for them. I think the danger of being fully put to sleep is a little bit too high. A good provider is you're going to use a ton of lidocaine. It's going to feel pressure, but hopefully with enough lidocaine and a real experienced provider, it won't be uncomfortable for more than about 10 to 20 seconds. It's not nothing, but it's the best way to know it. And I think the assurances of knowing what's going on there is worth the risks of going through it. Once you get a bone marrow, you get they make fragments so you can take a look at the particles of the bone marrow on a slide. And then this should be looked at by a hematopathologist and by your doctor to confirm the diagnosis. And there's characteristics of essential thrombocythemia, myelofibrosis, and PV that we see on this that should confirm your diagnosis. After you've been diagnosed, we need to assess your risk. What is the risk that this disease poses to you? Because I will tell you, some people have this diagnosis and they have very low risk. Certain people with essential thrombocythemia and high platelets, basically face almost no need for medications for much of their life. And so it's important to understand before you get any treatment, why am I being treated? What is my risk for a blood clot? What is my risk for heart attack or stroke? What is my risk for transformation? And you should ask your doctor what your risk level is. This is how we determine it. In essential thrombocythemia, there's 4 risk levels: very low risk, intermediate risk, and high risk. And it's really determined by your age, whether or not you've had a blood clot, and whether or not your disease carries the JAK2 mutation. If you have none of those, then you're very low risk, and I wouldn't even necessarily recommend aspirin for you. Then there's low-risk disease for people with a JAK2 mutation who've never had a blood clot and who are younger. And I debate whether or not patients in this category need aspirin, and I'm sure Gabby will talk about that a little bit. Intermediate risk describes people who are over 60, have never had a blood clot, and don't have the JAK2 mutation. In the past, in essential thrombocythemia, these are people that we gave Hydrea to, and now this is not a group that I necessarily treat with Hydrea. And this is a new designation that is arrived at by the NCCN guidelines in the last couple of years. And finally, high risk are people who've had a blood clot, are older than 60 years, and have a JAK2 mutation. And these people we know benefit from some kind of cytoreduction, meaning lowering their blood counts, because these people tend to have a much higher risk of strokes, heart attacks, and blood clots from their essential thrombocythemia. In Polycythemia Vera, there's 2 risk designations: low risk if they're younger than 60 and they've never had a blood clot, and high risk if they're older than 60 and have never had a blood clot. And generally, we use this to dichotomize who needs to take a medicine to lower their blood counts, medicines like interferon or hydroxyurea. Now, both people have to be assessed for symptoms, and sometimes we try medicines just to control the symptoms. But the real essential in somebody with manageable symptoms, the real key here is whether or not you need to take a medicine to lower your blood counts. In Polycythemia Vera, the fundamentals, no matter what your risk is to keep your hemoglobin or your hematocrit under 45%, and in women, I keep it under about 43%, and to use aspirin to prevent vascular events. Myelofibrosis, the risk is calculated using something called the DIPSS plus system, and that scores from your CBC, your chromosomes, your history. And this scoring system is used to not only predict how aggressive your disease is, but also whether or not you should be considered for a stem cell transplant, because individuals with higher DIPSS plus, who are younger and otherwise fit, may benefit from moving to a stem cell transplant. So once you've been diagnosed, and once your risk is assessed, and then you can start considering therapeutic options. And again, this is something Gabby will talk about with you, but I think the key things to ask your doctor is treatment necessary? How do we know that that treatment will work? And what side effects are likely? And this just talks a little bit about the treatments for essential thrombocythemia. Again, I don't want to step on Gabby's toes, but this just goes to show you that you can actually avoid cytoreductive treatment like hydreas, interferons, and nagrelide in ET unless people are in this high-risk category. This area here, I think about I debate it, and certainly in intermediate risk, there are some people who I will cytoreduce, but not often. In Polycythemia Vera, again, the keys here are making sure, you'll notice something, I'm just going to go back a second. Reducing cardiovascular risk factors, meaning controlling people's blood pressure, diabetes, and smoking, is an important part of no matter what risk you have. And so that's one of the reasons that I really echo what Anne said. We have much better medicines for blood pressure. We can tell people to stop smoking very easily. Those are much less difficult than taking a cytoreductive therapy, and yet they're an incredibly important part of controlling the disease in essential thrombocythemia and polycythemia vera. In myelofibrosis, again, if you're low risk and have no symptoms, sometimes we think about observation or a clinical trial. If you have symptoms and you're low risk, sometimes we use medications, ruxolitinib, interferon, or even Hydrea. And then in the high risk, we really want to think about clinical trials, and this is where we think about stem cell transplant. So these are basics, but it's something, sort of what I go through with patients once they've been diagnosed. Okay, so we've talked about how patients diagnosed, we've talked about thinking about treatment. I want to briefly, what's my time like, Ann? Okay, so next I want to talk about minimizing your infection risk and your cardiovascular risk. So infections come in many sources. They come in a bacterial, in viruses, or in fungi. Fungi include yeasts and molds, things like Aspergillus, et cetera. And it turns out that there is some increased risk for infections for people with myeloproliferative neoplasms. There is an increased risk in particular with myelofibrosis. And that could be because the disease causes some irregularities in your immune system. It could be because when the spleen is filled with if the spleen is busy making new blood, it doesn't do as good a job for fighting infection. Some people who are chronically ill have some debility, but also lower white blood cells or treatment with JAK inhibitors have been known to cause some infections. Neutropenia is when your neutrophils, one of the infection-fighting cells from your bone marrow, is decreased. And the way to know about that is just to have your doctor calculate your neutrophils. Certainly on some treatments, your neutrophils can go down. People on Hydrea sometimes have low neutrophils. You need to know what your neutrophil count is, and if it's under 1,000, your doctor needs to know whether or not you need to be on antibiotics to prevent infections. You want to sometimes take antibacterial medicines called fluoroquinolone, something like ciprofloxacin. I have most of my patients on, certainly if they're on ruxolitinib, I have them on acyclovir to prevent reactivation of certain viruses like the herpes virus or the shingles, et cetera. And in some patients, I also have them on antifungal medicines. I give all my patients the influenza vaccine, to them and to their family. The influenza vaccine is an excellent way of preventing the flu, and for anybody who's ever seen anyone die of the flu, it's not a joke. The flu vaccine saves lives, and it's an important component to care, is making sure that you're up to date on your vaccinations. If you're immunocompromised, meaning you either don't have a spleen because it's been taken out, or your spleen is so large that we think it's dysfunctioned, or you're on a JAK inhibitor, I ask people to avoid the live virus vaccinations. Now, the zoster vaccination used to be live. There is now a killed zoster vaccination. So if you want a shingles vaccine, then you want to think about getting the newest one. I think it was approved by the FDA late last year. And that one I do allow my patients who are immunocompromised to get. Infections can be related to treatment. For Jakafi, bacterial infections did happen on the Jakafi trials, on the ruxolitinib trials, mostly bacterial infections of the respiratory or urogenital tract. But severe infections were no more common than those that got placebo. There is a likely increased risk for rare infections, tuberculosis, and shingles, and that's another reason why I just keep an eye on it, and before I start anybody on ruxolitinib, I make sure I understand their TB status. I would avoid starting therapy while you're actively infective. So if you're not currently on therapy and you have an infection, we usually don't start people. And you want to watch for a few things, but most of the thing is just common sense. You don't need to wear a mask or anything, but just common sense measures like hand washing go a long way to prevent the spread of disease in all patients who have chronic diseases. What about arterial clots? Again, we talked about the heart and strokes, which can be either because blood flow doesn't get up there or because there's too much bleeding. These are the cardiac risk factors you all need to know: age, smoking, cholesterol status, what's my good cholesterol, what's my bad cholesterol, what my diabetes is. Now, there is this calculator that you can find online. It's called the Heart Risk Calculator. You can plug in all of your information, and then you can find out what's my risk of heart attack within the next 23 or 10 years. In this individual, a 60-year-old smoker with a total cholesterol of 210 and a blood pressure of 140/70, his risk of heart attack in the next 10 years is 23%. And that person does not have polycythemia vera. He doesn't have that extra layer. But if he stops smoking, takes medication, reduces his diet, and keeps his blood pressure under control, he can drop his risk of a heart attack from 23% to 13% without ever having to worry about his PV. And so one of the important things is to understand your risks and to understand what is modifiable here. Because we're going to present a lot of stuff to you that you are not in control of, and yet you are in control of everything here but age. And so it's something to keep in mind that I do have some control over how healthy my heart is. These are blood pressure targets. You really want to aim to have a normal first number less than 120 and a second number less than 80. That puts you in a normal category. And if you're not in that category, then you need to think about how I can move there with therapies like very simple, well-tested, very easy and inexpensive blood pressure medications. You want to completely abstain from smoking. There's some heart-healthy eating patterns that can help your heart. And then I actually also echo what Ann said, talking to a dietitian about what things that might also help your fatigue or your energy level can also be helpful. And then you want to keep your body mass index somewhere between 18 and 24. You can calculate that using this body mass index calculator that you can find online, and then you can sort of put yourself, I really want to move from here down to here. So I look at this picture every once in a while. I'm like, I have to cut my hair to look more like Mary Tyler Moore. Anyway, you can sort of move yourself along here and understand a little bit about your BMI, which is a good way to keep healthier over time. Cholesterol, I'm going to skip through this because we're getting a little bit, but there are ways to lower your cholesterol with diet, including oatmeal, soluble fibers, and omega-3 fatty acids. I will tell you, people with very high platelet counts, I tend to take them off of fish oil because fish oil is a little bit of an increase in your bleeding risk. So people with a platelet count over about 1.2 or 1.3 million, I typically recommend against fish oil. Exercise, sleep, stress relief from sleep I think is important. So if you're not sleeping well, that's something I think could work on. And I think one of the ways to work on that is improving your exercise and then using some meditation practices for sleep, which are more effective over time at stress and keeping your heart and blood pressure down as well. Venous clots, again, you'll hear about these later. They can happen in the brain. They can happen in the abdominal vasculature. These can be catastrophic. You want to know whether or not I need to be treated. And the first level of treatment, once people have had a clot like a pulmonary embolism or a venous thrombosis, is the better control of the disease. So these are people that need to be on cytoreductive therapies. And then finally, I just want to talk briefly about communication. I want you guys to remember, there's information about the patient, and sometimes the primary care doctor knows that person a little bit better. There's information about the disease, and sometimes the hematologist knows that a little bit better. But sometimes the primary care doctor doesn't know that much about the disease, and sometimes the hematologist doesn't know much about that patient, and the only person in the middle here is you. And so making sure that you are really doing everything you can to increase this communication is important. And sometimes what that means is that you get copies of the notes that your hematologist writes, and you give them to your primary care doctor when you see them, or your cardiologist or your dentist. Your hematologist, both your doctors, should be very willing to give you the consultation notes that they write, and they should be sending them to one another. In addition, a call, the biggest medical error that occurs is a lack of communication. So a call between your doctor, your hematologist, and your orthopedist before your surgery, or your gynecologist, those kind of things can be very helpful. So I really emphasize the role that the patient has here in increasing communication. And you can keep your own records to give back and forth. Many electronic medical records are now shareable, so you can authorize that if you go for a consultation with Dr. Malatarno, I can see the records from Hopkins just by a permission slip to access that electronic medical records. I would really encourage working with ancillary staff. If your doctor has an APP that has access, those people are sometimes much more accessible than the doctor sometimes. Just really engage in your care.